Hello everybody, welcome to my channel Island Daily. My name is Dr. Iman and I'm an optometrist, and today we're going to discuss when and how much prescription should be given to the pediatric patients. So let's get started. So first we are going to consider myopia, and I'm going to explain it to you guys with the help of a flowchart. So we are going to divide myopia into two groups if it is less than 5 diopter and if it is greater than 5 diopter. We are going to divide less than 5 diopter into subgroups, which is if it is less than 1 diopter and if it is greater than 1 diopter at the age of 3 years, or if it is greater than 3 diopter at the age of 1 year, right? So, if it is less than 1 diopter, then amblyopia is not a concern and we will not prescribe prescription to a pediatric patient if the refractive error, the myopia, is this much less. So, we are going to evaluate the patient at the age of 2 to 3 years and then again at the age of 5 years, to see if the myopia has progressed, and then accordingly we will prescribe the patient. So now, what if the myopia is more than 1 diopter at the age of 3 years and if it is more than 3 diopter at the age of 1 year? At this point, amblyopia is also not a concern. Let me tell you why. Because at the age of 3 years, the patient is not going to focus on distant objects. The child is only concerned at near targets. So 3 diopter is enough to make a child to view at near objects, and one more than 1 diopter, 3 years of age, is also not a very much high refractive error, so that it will not cause amblyopia, right? Now, what if the myopia is greater than 5 diopter? We will correct this refractor at any age. Regardless of age, we are going to correct this refractive error because there are so much chances of developing amblyopia, right? So there is a high risk for amblyopia, right? Now, there is another possibility. What if there is also a deviation present? So if the deviation is exotropia, we are not going to get into, even if it is phoria or tropia, if it is exophoria or tropia, or if it is esotropia or phoria. Remember, if it is exo and the patient has a minus number, we are going to give full correction. So for those of you who are thinking, why do we give full correction in myopes if they have an exodeviation? It is because the accommodative power is so much high that the eyes deviate outward due to high accommodative power, right? So we give full correction, that is a concave lens, to reduce the accommodative effort, right? What if the patient has an ESO deviation? We are going to keep the patient under correct. It is because myopes are already good at seeing near objects. Giving a full correction will reduce their accommodative effort, which can exacerbate their ESO deviation. And this case applies, this prescription applies to if the patient does have amblyopia, or if it does not have amblyopia. We will with these rules, right? So now, if the refractive error is less than 5 diopter, the patient can remove glasses at near target when viewing near. and remove at near. And if it is more than 5 diopter, the patient will wear glasses at every distance, all the time. So the patient will wear these spectacles for his lifetime until not treated with the refractive surgery or after, even after cataract surgery, some patients do tend to have a progressive myopia. So if the patient has more than 5 diopter, we will consider contact lenses, right? Now, speaking of follow-ups, in both cases, we are going to have a follow-up after 1 month, right? So, if the myopia is less than 5 diopter, the patient is going to have normal BCVA and he is going to have a normal binocularity of vision, and we will evaluate the patient after a year afterwards, right? And in amblyopic patients, there will be decreased binocularity, as we all know, and we are going to re-evaluate the patient according to his or her age. So this was myopia. Let me sum up it for you guys. If it is less than 5 diopter, we are going to divide it in two groups. If it is less than 1 diopter, we are going to reevaluate it at the age of 2 to 3 years and 5 years. If it is more than 1 diopter at the age of 3 years and more than 3 diopter at the age of 1 year, where amblyopia is not a concern, and if it is more than 5 diopter and if the patient is at high risk of amblyopia, and we are going to give correction to the patient despite his or her age. If there is squint present in exo, we are going to give full correction. In ESO, we are going to keep the patient under correct. And if it is less than 1 diopter, patient can remove glasses at near, and he is going to wear it for his lifetime. And if the myopia is greater than 5 diopter, he or she is going to wear it at every distance all the time. And we are going to prefer contact lenses. We are going to have the initial follow-up after 1 month, and the BCVA and binocularity is going to be normal in the patient having myopia less than 5 diopter, and there will be decreased binocularity and decreased vision in patient with amblyopia, and we are going to reevaluate the patient according to the age. So coming towards hyperopia, right? So since we know that the patient is a normal child is already 2 to 3 diopter hyperopic at the age till the age of 2 to 4 years, so we are going to divide hyperopia into three main groups. So if the hyperopia is less than 2.5 diopter, amblyopia is not a concern, and we are going to reevaluate the patient at the age of 2 to 3 years or at the age of 5 years, right? Now, if the hyperopia is 2.5 to 5 diopter, right? We are going to observe the patient's behavior towards near target, right? Now, if the hyperopia is greater than 5 diopter, again, that we are going to correct the patient, give prescription to the patient despite his or her age. Now, in both cases, there may be a risk of amblyopia. In this case, and there is a definitive risk, high risk of amblyopia if it is greater than 5 diopter. In both cases, we are going to evaluate amblyopia and going to treat the patient and going to give the prescription of the patient accordingly and we will advise passion therapy. Now again, if there is a deviation, if there is an esodiation or an exodeviation, if there is an esodiation, we are going to give a full correction. The reason if the patient is deficient in accommodation, the eyes are going to move inward because there is a stronger relationship between convergence and accommodation. And in exo, we are going to keep the patient under correct because we are going to leave a stimulus for accommodation so that the eyes will accommodate more and the eyes tend to correct their exodeviation accordingly. So, in this way, we can also treat exo accordingly. So, next is if there is no amblyopia present in the patient of less than 5 diopter, we are going to prescribe glasses to the patient according to his or her age until the patient will get older if the amblyopia is not present, right? But if the even if the amblyopia is not present and the hyperopia is greater than 5 diopter, we are going to correct the patient despite his or her age, and we prefer contact lenses. But in Pakistan, there is not actually very much practice of contact lens, so we tend to prescribe spectacles. So the initial follow-up will be after 1 month, and again there is BCVA and binocularity will be normal in hyperopia of less than 5 diopter, and it is going to be disturbed in the patient of more than 5 diopter, right? We will yearly evaluate these patients, and here the evaluation will be based on the child's age. Right? So this was hyperopia. Let me sum up for you guys. If the hyperopia is less than 2.5 diopter, amblyopia is not a concern, but still you have to evaluate if there is some kind of a hyperopia present. If not, you're going to reevaluate the patient at the age of 2 to 3 years and 5 years. If it is 2.5 to 5 diopter, observe the patient's behavior. You have to evaluate if there is amblyopia or any deviation present. If amblyopia present, you're going to give prescription to the patient. And if there is greater degree, if the hyperopia is more than 5 diopter, you are going to prescribe the patient despite his or her age. There is high risk of amblyopia. If there is deviation present in ESO, you're going to give a full correction. In EXO, you're going to give an under correction. If it is less than 5 diopter, you're going to prescribe patient until she gets older. If the amblyopia is not present or if there is no deviation present. If it is greater than 5 diopter, even if the amblyopia is not present, there is no deviation, you're going to prescribe the patient a full-time prescription. We will prefer contact lenses in the countries like Pakistan. If there is no good contact lens practice, you can also prescribe glasses. You are going to evaluate the patient after 1 month. The initial follow-up, the BCVA binocularity will be normal in less than 5 diopter, and it is going to be disturbed in patients of more than 5 diopter, and there will be yearly evaluation in less than 5 diopter, and you are going to evaluate the patient according to his or her age if the hyperopia is greater than 5 diopter. Now, coming to astigmatism. So, we are going to divide astigmatism into two main groups, which is if the astigmatism is less than 1.25 diopters and if it is greater than 1.25 diopters. Now, If it is less than 1.25 diopter and amblyopia is not a concern, you have to monitor the patient and you have to have a follow-up of at the age of 2 to 3 years and at the age of 5 years, right? Now, if the astigmatism is more than 1.25 diopters, you have to check if the astigmatism is stable or unstable. Usually, when a child is growing, the corneal curvature is also changing, the lid tension, or with sleeping positions, there may be a temporarily induced astigmatism. So, you have to check on 3 visits of 1 month if the patient has a stable or unstable astigmatism. If the astigmatism is unstable, you are going to monitor and it will have a follow up at the age of 2 to 3 years and 5 years. However, if the astigmatism is stable, you will consider prescribing, right? So, if the astigmatism is stable, you have to divide the patient according to age. If the patient is younger than 1 year, you are amblyopia is not a concern at this age. As I've told you before, the patient is not going to focus too much. If it will have a near vision, sufficient near vision to see near objects. So amblyopia is not a concern at this age. Is not a concern. And if the patient is older than 1 year, then we can consider amblyopia monitoring, right? So for the monitoring of amblyopia, and if the patient is of younger than 1 year, you are again going to have a follow-up at 2 to 3 years and at 5 years. And if the patient is younger than 1 year, we are going to divide amblyopia again at if it is less than 5 diopter or if it is more than 5 diopter, right? So if it is less than 5 diopter, we will prescribe glasses according to the age until unless the patient gets older to tolerate to tolerate cylinder, we are going to prescribe give the prescription until the patient gets older, right? If the amblyopia is not present, if it is present, you are going to prescribe despite the age, right? If it is not present, so if it is not present and it is more than 5 diopter of astigmatism, you are going to prescribe the patient contact lenses. And in countries who are not good in practice of contact lenses, you are going to prescribe spectacles, right? And in both cases, if you have prescribed uh, cylinder until an older age, you are going to give a prescription, full time prescription, right? Again, in this case, the binocularity and BCVA are going to be normal, right? And you're going to yearly evaluate the patient. And if there is amblyopia present, you are going to have reduced BCVA and reduced binocularity, and you are going to reevaluate the patient according to age. Now, having a quick recap. So we are going to divide astigmatism into less than 1.25 diopter and more than 1.25 diopter. If it is less than 1.25, you will monitor and have a follow-up at 2 to 3 and 5 years. You are going to see if the astigmatism is stable or unstable at the age of one. If it is 1.2 or more greater than 1.25, it is if it is unstable, it is a good sign. You are going to monitor and have a follow-up at 2 to 3 and 5 years. after 3 visits of 1 month, right? If it is stable, you have to consider prescribing. If the patient is less than 1 year and there is no amblyopia, there is no risk of amblyopia, and you're again going to have a follow up at 2, 3, and 5 years. If the patient is of the 1 year, you're going to have an amblyopia monitoring. If there is no amblyopia person, you're going to prescribe the patient until unless he or she is going gets older. If it is more than 5 diopters, despite the age, you are going to give correction. Contact lenses are going to be preferred, but spectacles can also do the work. And in both cases, the patient is going to have a full-time prescription. The binocularity and BCV are going to be normal, and if the astigmatism is less than 5 diopters, and if it is more than 5 diopters, there is a high risk of amblyopia, and their BCV and binocularity is going to be disturbed, and you're going to reevaluate the patient according to his or her age, and you're going to reevaluate the patient if the astigmatism is less than 5 diopter. Now comes anisometropia. So in anisometropia, you have to check if the anisometropia is unstable or if it is stable. If it is unstable, you are going to monitor and are going to reevaluate the patient at the age of 2, 3, and 5 years, right? And if it is stable, you have to see if it is less than 1 diopter or if it is more than 1 diopter, right? If it is stable and if it is less than 1 diopter, you are again going to monitor and going to reevaluate the patient at the age of 2, 3 years, and 5 years. But if it is more than 1 diopter, you are going to divide it in if it is myopic or if it is hyperopic or astigmatic, right? So if the patient is myopic, you have to see the age. If the myopia is if the child is less than 4 years, you are going to monitor and going to reevaluate the patient at the age of 2, 3, and 5 years. And if the myopia is greater than 4 years, you are going, or if it is hyperopic and astigmatism, you are going to evaluate for binocularity and dysfunction and motor coordination, all those tests which are necessary because there is a present a high risk of amblyopia, right? So you cannot ignore anisometropia. Also, if the myopia is less than 4 years, you can also there is also some risk of amblyopia present. So in both cases, you are going to evaluate for binocularity and amblyopia and all the motor functions, right? Now, if there is everything is fine and there is no amblyopia present, and if the patient's age is 5 diopter, and if it is more than 5 diopters, if the anisometropia is less than 5 diopters and there is no other dysfunction or amblyopia present, or there is no deviation present, you are going to prescribe the glasses until the patient is older enough. And if it is 5 diopter, again, you are going to prescribe the prescription despite the age, right? The initial follow-up is going to be after 1 month, right? Again, if it is less than 5 diopter, the binocularity and BCVA are going to be normal. Like, it is not a promising rule, but there are high chances of being normal. And if it is greater than 5 diopter, there are very high chances of disturbed binocularity and BCVA if it is greater than 5 diopter. And again, you are going to evaluate it according to the patient's age. And here you are going to have a yearly evaluation. So again, in isometropy, we have two groups, unstable and stable. If it is unstable, you're going to monitor, and at the 2 to 3 or 5 years, you're going to have again a follow up, right? If it is stable, you have to see that it is less than 1 diopter. There is not a problem. You have to monitor, and you will have again a evaluation at 2 to 3 and 5 years. If it is stable, you have to see if it is myopia or hyperopia according to age. If it is myopia, if the patient is less than 4 years of age, it is not, amblyopia is not a concern. Mostly you have to monitor, and you will have a evaluation of 2 to 3 and 5 years of age, but sometimes it can also lead to amblyopia, so you have to assess it as well. If it is for more than 4 years of age, there are increased chances of amblyopia and disturbed motor functions. So you have to check for any deviation, or you have to check for amblyopia and assess it. If it is more than one diopter and isometropia, there are very high chances, or hyperopia or astigmatism, right? So there are a high chance, same there, you are going to assess for binocularity and amblyopia. And then if it is less than 5 diopter, you are going to prescribe, and no amblyopia is present, you are going to prescribe according to until the patient gets older. And if it is more than 5 diopter, you are going to prescribe according to age. Again, the contact lens are more suitable. You're going to have the initial follow-up at 1 month, and binocularity and BCVA are going to be normal. There are high chances of being normal. And if it is less than 5 diopter, and you're going to have a yearly evaluation, and it is going to be they're going to be disturbed binocularity and BCVA if it is greater than 5 diopter, and you are going to have a evaluation according to age. So these were the rules which are set up by optometrists to prescribe spectacles to the pediatric patients. I hope I have made everything clear so far. Thank you for watching my video patiently, and pardon for my writing. Thank you for watching. Take care of yourself, and do like and subscribe. Thank you very much.